It is an absolute pleasure to introduce Professor Richard Williams, Emeritus Professor. Did I get that right, Richard? That is a qualification.
Yes.
Yes, of Mental Health Strategy, Welsh Institute for Health and Social Care, Director of Psychosocial and Mental Health Programme in the Faculty of Pre-Hospital Care in the Royal College of Surgeons of Edinburgh and Royal College of Surgeons of Edinburgh. There was so much in your job title, Richard, that I had to condense it significantly. So please feel free to introduce your full titles in a moment. But you'll be talking about the experiences that stress NHS and social care staff during the pandemic, the impact of secondary stressors and model of care. Over to you, Richard. Thank you so much.
Well, thank you very much. I'll talk for 20 minutes or so. This is a kind of brief introduction to what has become a very big area for me, because I've been working on this throughout the pandemic. And indeed, last week was the first break I took in well over 2 years. So I've been advising various people, including the various English government agencies, which is an interesting challenge. But let's move on. And I want to address a few sentinel questions here. The big pressures on staff, were they the same during the pandemic? Were they different? And where are we now with those pressures? That's a question that lurks in the background. We started out in the pandemic advising government and various bodies, including health agencies, on the basis of our acquired learning about what happens to responders to disasters. And of course, our military experience. I had 43 years as a reservist. So I know what happens to people who are army veterans. But would that help us with the pandemic? That was the second question. And overall, what have we learned? And I would answer that right now by saying some of us have learned a lot and some organizations don't seem to have learned enough yet. These are difficult topics. Let's go on. These are some of the previous things which I ground my teeth on. First, I've got this NATO document. I led the work for the NATO Joint Medical Committee to come up with a regime, some kind of approach to caring for people who were affected by major incidents, conflict, disasters, and terrorism. And that was published at the very beginning of 2009. And then various documents here that have appeared. This is a college document, College of Psychiatrists, and this is a journal article here, and then an aid memoir, which I updated for the pandemic. But it's this document that really is the grounds for my claiming to say something about Scotland, because the College of Surgeons of Edinburgh, which claims to be the first inaugurated Royal College in the UK, was very keen to take an active stance on what we can do for the staff. And this had got nothing to do with the pandemic, because the work started in 2018 and it didn't finish till earlier this year because the pandemic intervened. But I'm going to talk about some of the things we did and the fact that they did seem to apply to the pandemic. So these are the things I want to cover in the next 15 minutes or so. We talk about distress, but what is it? I want to introduce this notion of primary and secondary stressors. There were an awful lot of papers, a huge number of papers have been written about people's mental health during the course of the pandemic. But what was it that stressed people? What was it that stressed the staff? I've got a very clear idea about that now. And that's led to us creating a model for preparing, supporting, and caring for and leading staff of particularly healthcare services, but I have no other wish than to think that it might well be extendable to social care too. It's just that I haven't had a chance to test it out. But it's built on a concern that I've had for a long time, that this is the world of Humpty Dumpty. This is the world in which words mean what I want them to mean, not what they do mean. So we talk about well-being, health and well-being. We talk about mental health. We talk about mental ill health. We talk about mental disorders. But how does this all fit together? And in fact, it does and it doesn't. But I want to come up with the conclusion that we need to sustain our colleagues who are well. We need to respond to colleagues who are distressed. Distress is common and it's not a mental disorder. I call that the psychosocial agenda. And we need to respond promptly to colleagues who look as if they may be developing a mental disorder. All right. In the course of this, I've contributed to the pilot paper. This paper here, the green one, is where we followed and tracked staff through the pandemic and wrote it up as a kind of narrative. This is a paper that we started out with, which we wrote in 2018, published in 2019. Would it have any bearing on what staff needed? And the sad answer is, yes, it does. And it was pretty good at predicting where we'd end up. And this is a paper which will become more relevant to, like, when I explain the difference between primary and secondary stressors. Okay. What we've known for a long time about staff of responding services, and of course, the Faculty of Pre-Hospital Care, that's what they do for a living. They arrive at the scene of your denouement from a height, from a helicopter or a very fast car or something like that. And they bring highly specialized services to your front door. Literally. These are people who can do open heart surgery, well, not open heart surgery, but open chest surgery in a high street. They do save a remarkable number of lives. I have the greatest affection for these folk. But they're also quite sensitive. They're not like surgeons at all, or the archetype we have and carry around with us, which is very unfortunate and wrong. Stress may manifest in a whole variety of ways, but we've known this through countless pieces of research. We also know just how hard it is to deliver healthcare. We call this emotional labor. Just in the ordinary course of events, but particularly during the pandemic, remaining compassionate and caring for your customers, while also going home and being a decent family member and looking after yourself, is a very difficult combination. You see, there's a whole business of being professional. Somebody said that, didn't they? That being professional is important. People think this is true, that we don't want our staff breaking down in front of us or behaving in ways which are seen to be non-professional. But in fact, they may feel like doing so a good chunk of the time. But holding that lot in takes an awful lot of hard work. So the kind of work that people have been doing through the pandemic is depleting, it's tiring, and it creates burnout. And I think that a substantial proportion of the staff of the NHS are still suffering that right now. It hasn't just gone away. Okay. So let's come back to this. So what happens? This is the kind of field from which we started. We know an awful lot about emergencies and major incidents and its relationship with our feelings, our experiences, and mental illness. Distress is very common. As I say, it's not a mental illness. It's the way you're affected by being in contact with something which is highly emotional. And a large number of staff in the NHS face this on a day in, day out basis. So why haven't we talked about this much before? I'm afraid we haven't talked about it enough. But if we get beyond distress, we get to a range of other psychological, social, psychiatric, and neuropsychiatric problems. So grief, but we don't talk about some of these things enough, like substance misuse, depression, anxiety disorders. PTSD gets mentioned a lot, on the other hand. Everybody knows about PTSD, but in fact, it's not the most common response. But you have to be suspicious if you see levels reported of greater than 30% of the staff. We've talked an awful lot during the pandemic, but this has been around for some time. It came up in the American military first, when people with PTSD didn't recover. And we found out there were moral elements to their malady, that they were morally distressed, or indeed, in a more severe form of that, morally injured. And yesterday I was at the College of Psychiatrists Congress in Edinburgh. I was looking at slides shown by a colleague showing that as this level of distress about moral matters, not being able to do the work you wanted to do, being asked to make decisions which are contrary to your moral code, then so the chances of developing depression and PTSD rise. But the next green one down is really, really important to me. What we've found in the past is under the pressure of emergencies and major incidents, there is an erosion for staff of their interpersonal relationships and sense of community. And that disrupts the social contexts in which people and groups of people function. Haven't we seen that in big style in the pandemic? Will it come back and grip us again? This pandemic ain't done yet, I have to say, not wanting to be a doom laden, but it isn't done. If you're a member of staff, you do this sort of thing for your work. So talking about a response to a single incident isn't right. And that's certainly true in the pandemic. As good as you were yesterday with a group of patients you had then, it all starts all over again when you're next in the hospital. Or looking after people at home. Doesn't matter what the location is. So the more complex and demanding things get, the more the risks go up, that sustained distress increases, that the number of people with new mental disorders goes up, and there's a list of them under item 3 there. But there's something else more pernicious at work here, which is the indirect effects of disasters on people who are exposed to them are to increase poverty, to increase domestic and community violence, and we don't speak much of that. There are threats to people's human rights, and it changes people's societal and social relations, as I've said. And those 4 things are summarized by Michael Marmot, no less, as the social determinants of mental health. So we acquire some risks to our mental health, which are sustained. Let's come back to some other things. And what about this distress? Well, I owe this slide to a Scotsman, the late great David Alexander. Sadly died, taken from us too soon. But he produced these lists of experiences that people have when they're distressed. Now, we followed up on that by looking at what happens to people who were exposed to the Manchester bombing. And these are the results, that the white ones are common and the green ones are less common and have more serious portent. That the white ones are the things which happen very, very frequently, and the green ones less often, but they are much more likely to lead to mental disorders. So we end up with a graph like this of common responses, a common form of distress, which affects, and I take it now as an a priori a statement, that 100% of people who are involved in some incident like the Manchester bombing and become distressed. It's very unusual for people not to show some emotional response. But 50 to 60% of them recover quite quickly. We used to say within a fortnight they like to recover. I think we now know that that's somewhat optimistic, because we found that the numbers of people in the slur group to recover has gone up as we, in fact, most of the people we interviewed in depth in Manchester, or after the Manchester experience, was that they took 2.5 years to recover from their distress. So distress is neither benign nor a pleasant thing, and yet it's not an illness. But the deteriorating response, where people's stress gets worse, and the high stress people who become high stressed very soon, these are two groups of people, accounting for about 20% of a population exposed to stress that comes from a major incident, are much more likely to develop mental disorders. Okay, so what is it that causes this distress? The early papers that came out in the pandemic all talked about staff being worried about the impact of the virus on them, their families, their patients. True, but there was more to it than that. In a book chapter, Neil Greenberg and I said that leaders should be cautious about ascribing the stress that staff experience as necessarily resulting from what they've witnessed and the work they have done or not done. True too. So we were cautious about the staff during the pandemic. What we found was that much more weight should be directed at what we call secondary stressors. These are stressors which don't appear in the limelight. This isn't the virus. These are about the social factors and people's life circumstances that often exist before, but impact during the event. Or they're about societal responses to the major incident or emergency. Let me translate that for you into the pandemic very briefly. The chief thing that staff complained about, and they complained about it for 2 years, was the lack of adequate PPE and the changing instructions about how to do it, how to use it, which to them seemed more related to the extent of the supply than it did to some rational kind of scientifically derived best practice. I'm putting it cautiously because these are emotional experiences. But if you track that back, why didn't we have PPE available? Where had the supply gone? I know for a fact when I was involved in the H1N1 pandemic that there were warehouses of this stuff. Well, where had it gone in the interval? And it's usually cycled through practice, not kept in the warehouses because it goes out of date, but cycled through into practice. And societal responses about PPE were to take it seriously, but not necessarily to invest as wisely as many people might have hoped. So what we've got here is a secondary stressor, the PPE thing. It's not organic to the virus, but you can't actually function well without good PPE, because the principle of reciprocity says effectively, the more risk you ask staff to take, the more you should care for the risks that are associated with what they're doing. But it was also a part. It was prior. It was a defect in planning, but in my view, but there's an inquiry which will actually rule on this. Not for me to say, perhaps, but that would be my conjecture. And it's about societal responses when the issue came to light. So that's a good, but hang on, were these secondary stresses just about the pandemic? No, they're not. This is a list of stressful circumstances that I asked a group of accident and emergency staff to create for me. I separated them along with a colleague into the primary and secondary headings. What the staff did for me was to write them down. So these are frontline staff who wrote down a list of things in their work which is stressful. And this was well before the pandemic was even thought about. And you see that certain things resonate, the moral and ethical dilemmas, about anguish resulting from the need to triage. If I decide person gets a treatment ahead of somebody else, I feel guilty about that. And there's some American work which shows that guilt, which is part of a moral distress kind of framework, goes on for several years. So, okay, these are not new. What actually happened was that the existence of the primary stressors, the virus, almost kind of made the secondary stressors much more important. So on all the phone lines and helplines that NHS England set up, it was mainly the secondary stressors that staff phoned in about, not exclusively. Now here's a headline from a well-known journal. It is the Metro. And I know people have that in Scotland because I saw a copy in Scotland this morning as I was at the airport. And this was a narrative written, a 2-page article written by a trainee in intensive care medicine. These are the people who provide the medical staff for ICUs, intensive care units. And she knew she'd taken on a very difficult job, this young woman. And she was prepared for it. What she wasn't prepared for was, to put her words in other terms, the secondary stressors, the loss of physical spaces, messes, on-call rooms, canteens, and the loss of team structures. Doctors were no longer part of a team, just another number on the rota, she wrote. So we've gone from having teams to having groups of people who work together. And that is quite erosive. And indeed, the previous chief medical officer for England said in her valedictory interview on Desert Island Discs that there was one thing she regretted, and it was not reconstituting the firm structure. And it's about workloads. And it's contributed to burnout. So what it is somehow the pandemic has drawn our attention to this. It's not new, but it's certainly rife now. So the frequency of distress of this nature has gone up dramatically. And staff are now feeling still very fatigued and ill understood, I think. So what do we do about it? I'm just looking at the time, make sure I don't go on too long. Couple more minutes. Social support is critical. But actually sitting down with somebody and actually listening to them. And that's quite a hard job to do, It's not easy to hear these things, but providing a web of relationships that staff perceive to be loving, caring, and readily available. And it's this perception of support, of entitlement to it, which is so important. It's important that you receive what people purport to offer, but it's not quite as important as perceptions that you're entitled to it. And that is about ensuring that staff have somewhere to take their concerns, be they buddies, leaders, managers. It's about having a socially cohesive group of staff, which is why I think teams, real teams in which there's a shared social identity, are important, and not just rotating people. There were 1 or 2 hospitals in London which, under the pressure, allowed the staff to create their own rotas, and they worked so much better. And it was this sense of belonging and the leadership that came from it, which was critical. So the early intervention, I think I could have written this slide from what we knew about disasters, but it was right during the pandemic too, that the early interventions consist of general support and bolstering the recovery environment, and not psychological treatments. In fact, at that time, psychological treatments are often contraindicated. What is important is helping staff to restore their agency and their perceptions of themselves as effective, valuable, valued people. In some places, in places in the NHS, staff have received those things, but not in all. My daughter, who's a neonatologist, was on call one recent weekend, went to see if she can find some food, couldn't find anything. There was no catering for staff in her hospital at all during the weekend. These are surely things that we can put right. And what I'm getting is that some of these interventions must deal with the secondary stressors, and not be able to get a meal is actually a very potent secondary stressor. And it certainly turned out to be so during the pandemic. And it lies, this sort of thing, dealing with it, lies at the heart of this military acronym called PIES, of designing your practical interventions where staff are as immediately as possible, with an expectation that people will recover. And they need to be as simple as possible. So I think the hospital my daughter works in has got a problem. I would say that just on this rather slim evidence, which I think it needs to deal with, because they haven't sought out and dealt with the secondary stresses that the staff experience. Going on from that, we need to think about creating peer support programs. Now, I'm coming to the end now. I'm not going to say a great deal more because I probably overrun. But this is the Stevenson Farmer Review, something we all ought to know, because it's not about clinical practice. It was written for the Prime Minister at the time, in which Stevenson and Farmer observed that if we look at the staff in any enterprise, and this wasn't just written about the NHS, but it included the NHS, then there are 3 groups of staff in a sort of dynamic equilibrium. There are people who are thriving in their work. There are people who are struggling in their work and might be distressed. There are people who are ill at work or possibly not at work. I think it's highly likely that during the pandemic, that big green bubble reduced in size. The mild green, the light green bubble expanded very considerably, and the light yellow bubble expanded a bit, but not as much as the light green one. So there are 3 things we have to do, that tells us. We have to keep, and this is what I call the well-being agenda, we have to keep the people who are well well, we need to sustain them. It's about workforce development. And it's not just that, but it's about developing workplaces that are suitable for the heroes that we called the staff. That went down very badly with most people in the NHS, by the way. But if they are heroes, then they need to work somewhere which is supportive of them and provides this informal support and active listening. So that's the well-being agenda, which I separate from the psychosocial agenda, which is about responding to staff who are struggling, probably distressed. And this is where psychosocial care, which I don't have time to go into, but it's not a mental health service responsibility, it's an employer's responsibility. You see, I think having a strategy for this belongs at the level of the board for every healthcare organisation, having a balanced ticket of interventions for staff, and each of these three, sorry, I've flipped off it, these three levels is critical. And we therefore need to be clear about what we mean. That the mental health agenda is about detecting people who are probably mentally ill and need mental illness treatments, evidence-based treatments. The psychosocial care isn't necessarily the responsibility of a mental health service, but in countries like England, where they've separated mental health care from the rest of healthcare, not in Wales or in Scotland, as I understand it, the psychosocial care and belongs, and the wellbeing agenda belong with the employers, not with the mental health services. So it must be for every board, it seems to me, to be able to say they've got a strategy for a balanced ticket across these three activities. Now, I guess I should stop at that point, shouldn't I? And let me just say that this is, I rarely recommend books, but this is Rebecca Solnit, who is a social activist and social historian from the West Coast of the States. And she's written this book, A Paradise Built in Hell, analyzing 5 big disasters in the US. And she says this, and it's true, that people know what to do in a disaster. It's loss of power, this agency thing is the disaster. And I think that's what's happened to a lot of our staff in healthcare, is that they have felt unempowered. And therefore, we need to think about that. She points out that solidarity, altruism, and improvisation are within most of us and appear at these times. Do you remember that? Up till about June of 2020, all those things were happening, but we know from other research that they stop.
Thank you so much, Richard. Just before we move on to the next session, there were some feedbacks in the chat. So just a quick one from June. You talked about PPE. She asked, to what extent did wearing PPE contribute to stress levels, given that caring for patients is part of the job? You pretty much summarised that there, that was a secondary stressor. And then some feedback from Yvonne, who says, I think the societal response to care homes through the pandemic had a large impact on staff mental health, that stigma had one of the biggest impacts that she'd witnessed. And in particular, Operation Copper sent the wrong message to staff and only added to that distress. So thank you so much.
What can I do but agree? Yes, of course, spending hours and hours sweating inside PPE when you're working hard is difficult. A lot of nurses, when it was short in supply, didn't want to take breaks because they'd have to take it off and put a new set on, and there might not be enough for tomorrow. It was the kind of guilt they went through. And that was of no small impact.